Hello, everyone. My name is Omer Awan. I'm a professor at the University of Maryland School of Medicine. I want to do a high yield MSK board review for the ABR core exam. I'm going to show 30 cases with 30 questions, hopefully in under 30 minutes. So let's go ahead and begin. This is case number 1. Here we have a sagittal T2 fat side image through the knee. And the question that I have for you is, which of the following structures is injured? And if we take a look at the knee MR, notice that there's bone marrow edema along the anterior lateral femoral condyle and the posterior lateral tibial plateau. That should automatically make you think of a pivot shift injury. And of course, with a pivot shift injury, the ACL will be torn in 100% of cases. So of course, the answer here is an ACL tear, okay? And this is a very common high yield question for the core exam. They may not even show you the ACL, but you should recognize automatically that the ACL is going to be torn in this instant with this characteristic bone marrow edema pattern. So bone marrow edema patterns predict the soft tissue structure that's injured in the knee. And in this case, the soft tissue structure that's injured is the ACL. You can see on this sagittal image, there is complete rupture of this ACL. Case 2, we have a frontal view of the hand. And the question that we have is, the underlying pathology responsible for the imaging findings depicted is what? Well, here we have a shortened fourth metacarpal. Okay, and that's usually due to pseudo hypoparathyroidism or pseudo hypoparathyroidism. And of course, the answer here would be C, end organ insensitivity to the parathyroid hormone. This occurs in pseudo hypoparathyroidism. Other findings are short metacarpals, short metatarsals, and coned epiphyses in the pediatric population. Case number 3, we have an ultrasound image through the shoulder. Okay, this is looking at the supraspinatus tendon. And just for, reference, this here is the subcutaneous fat. This area here is the deltoid muscle, this hypoechoic structure here with hyperechoic strands, which are connective tissue within the muscle. This bright line here is the peribursal fat here. And then this, of course, here, this hyperechoic fibrillar structure is the supraspinatus tendon. Okay, and then this hyperechoic area here is the cortex, the humeral cortex here. Okay, so, and then there's posterior acoustic shadowing from the cortex. So the question that we have is, which of the following is not associated with a rotator cuff tear on ultrasound? Well, here we have a full thickness rotator cuff tear, right? This anechoic defect. You can see the strands of the supraspinatus tendon have been retracted, right? And all this black area, this anechoic area, is fluid or hemorrhage. So there's a full thickness tear extending from the articular surface, the bone, to the peribursal fat, right? From the articular surface to the bursal surface. So this is a full thickness rotator cuff tear. The finding that's not associated with rotator cuff tear on ultrasound is convex contour of the bursal tendon surface, right? Because it should normally be convex, right? When it becomes concave, that's a sign of a rotator cuff tear. A fluid-filled gap is also a sign. Non-visualization of the tendon is also a sign, but the cartilage interface sign is also a sign. So this here, notice that you can see this area here, and I want to come back here just to show it. This area here, this hypoechoic area right above the bone, that's the articular cartilage, right? You should never see that on an ultrasound. Like, we don't see it here. We see this because of the ultrasound properties of, posterior acoustic enhancement from the anechoic defect, right? So when you see, this is known as the cartilage interface sign. If you can see it, that's a sign of a rotator cuff tear on ultrasound. So very important principle here. So that's the answer here. The bursal tendon surface should remain convex. If it's not, the tendon is torn. And we discussed the cartilage interface sign in this example of a full thickness rotator cuff tear on ultrasound. Case 4, we have sagittal images through the elbow. Okay, this is a T1 weighted image. What normal variant is depicted here? Well, notice here on the posterior lateral capitellum, we don't have cartilage, right? So this is known as a pseudo defect of the capitellum. Nobody has cartilage here. This can be mistaken for an OCD or an osteochondral defect, but this is a normal variant that we see. So this is a nice example of a pseudo defect of the capitellum. Posterior laterally, there's no cartilage there. So moving on to case number 5, we have a frontal view of the knee showing a finding. So what's the next best step in management? So perfect segue to this case. We see this ossific fragment here along the lateral aspect of the medial femoral condyle. This is a nice example of what an osteochondral injury would look like. This is the most common place in the body to get an osteochondral defect or injury. An OCD is exactly like its name implies, a defect of the bone and the cartilage. Osteo for bone, chondral for cartilage. Of course, we want to look to see if it's stable or unstable, and we do that with an MRI. So MRI will always be the next best step in a case of an osteochondral defect. On MRI, you're looking for fluid undercutting the defect, like this. That would indicate instability, or T2 cystic change surrounding the lesion that we don't see in this case, but this is a nice example of instability because it's like a free, loose fragment. Okay, so MRI is the best test to look for stability or instability of an OCD. Case number 6, we have a frontal and lateral view of a patient that's had a total hip arthroplasty. What's the most likely diagnosis here? Well, we have a lot of lucency, extensive lucency along the acetabular cup, extensive lucency along the, trochanteric region. The differential diagnosis for more than 2 millimeter lucency would be infection, aseptic loosening, or particle disease. We don't see a fracture, so D is not the answer. But notice the eccentric positioning of the femoral head within the acetabular cup. This distance from here to here is much less than the distance from the medial margin of the femoral head to the medial margin of the acetabular cup, right? There's an eccentric positioning of the femoral head component of the prosthesis in the cup. That suggests polyethylene component wear, which is an example of particle disease. So particle disease is the answer here. Very important case for the core exam, right? So you want to look for radiolucencies around the prosthesis and eccentric position of the femoral head within the cup. Nice example of component wear. Case number 7, we have a wrist arthrogram, right? We've injected contrast into the radiocarpal joint. The question is, what's the most likely diagnosis? Well, the key to all arthrogram cases is to identify where contrast should be and where it shouldn't be. So contrast should only be in the radiocarpal joint, but we have contrast in the distal radioulnar joint. See this contrast here? That indicates that there's a TFCC tear, right? Because that's the barrier. That's the barrier that's going to prevent contrast from going from the proximal carpal row or the radiocarpal joint into the distal radioulnar joint, right? So this is a nice example of a TFCC tear. Okay, so when we have contrast going in a location that it shouldn't be, that indicates that there's a tear of some sort. In this case, if you see contrast in the distal radioulnar joint, that means that there's a TFCC or a triangular fibrocartilaginous complex tear. All right, case number 8, we have a axillary view of the shoulder. Okay, this is the humeral head, this is the glenoid. Which tendon is likely involved in this case of calcific tendonitis? Well, we have amorphous globular calcification right here. So this is a nice example of calcific tendonitis, but this question is, testing your ability to understand anatomy. These are the 4 rotator cuff tendons, right? 3 of these insert onto the greater tuberosity, 1 inserts onto the lesser tuberosity. Notice that this ossific protuberance is the lesser tuberosity. So this must be calcific tendonitis associated with a tendon that inserts onto the lesser tuberosity. And that, of course, is the subscapularis, right? So that's the answer here. Nice example of subscapularis calcific tendonitis, best seen on this axillary view of the shoulder. Moving on to case number 9, we have an axial T1 and axial T2 fat side image through the proximal hips, showing very obvious finding here. This is a case of acute osteomyelitis. You have replacement of the marrow. The fatty marrow should be bright on T1. It's replaced with dark signal. You have this large ulcer. All this fluid and phlegmonous change extending to the level of the bone. A lot of soft tissue edema in this case of acute osteomyelitis. Well, the question is, confluent abnormal signal on what MR sequence adds specificity to the diagnosis of osteomyelitis? That, of course, is T1. T1 is more specific. T2 is more sensitive, right? So we often look at confluent dark signal that replaces the marrow on T1, and that's what we see here, okay? So very important, again, for the core exam. Osteomyelitis, T1, confluent dark T1 signal adds specificity to the diagnosis of acute osteomyelitis. Case number 10, we have a frontal view of the wrist here, showing an obvious abnormality. What's the next best step in management? Well, the finding you should notice is that this lunate is pie-shaped. There's abnormal alignment of the proximal carpal row, right, between the scaphoid, lunate, triquetrum. So that indicates there's some element of carpal instability. I've only shown you a frontal view, so one view is no view in radiology. So of course you would want to get a lateral view because right now, this could be anything. This could be scapholunate rotary subluxation, a perilunate dislocation, a midcarpal dislocation, or a lunate dislocation. The lateral view will answer that question for us. So we want to do a lateral. And this, of course, is a lunate dislocation because the lunate has dislocated 90 degrees volarly or anteriorly in this case, right? So one view is no view. Always look to assess and get a second view if you need to, okay? So nice example of a lunate dislocation. Case number 11, you have an axial view through the lower leg. There's a lesion here in the tibia, right? Looks like there's rings and arcs matrix mineralization here. This is a chondroid lesion. All the following can be seen in the transformation of an enchondroma to a low-grade chondrosarcoma, except, well, we know that endoscopic scalloping greater than 2/3 of the cortex is worrisome for a low-grade chondrosarcoma. Destruction of the chondroid matrix is worrisome. Clinical pain is worrisome, but peripheral and septal enhancement can be seen in even a simple enchondroma. So C would be the answer here, and that's what we see here. So, the findings that you really want to look for is endoscopic scalloping. Notice that this is like 90% scalloping, right? The thickness of the cortex is right here, but notice that the cortex has become extremely thin here. Another finding you can look for is if you do a bone scan, the uptake in the lesion, if it's greater than the uptake in the anterior superior iliac spine, as it is in this case, that's worrisome that this could be transformation to a low-grade chondrosarcoma, okay? Case 12, we have another ultrasound image through the knee, right? This is the medial aspect of the knee. This triangular hyperechoic structure is the meniscus, right? This is the bone here, this hyperechoic area. This is the femur. This area is the tibia. This area here is the medial collateral ligament that's studding the femur, the femoral cortex. Notice on the left side is totally normal, nice and thin, no fluid or edema around it. On the right side, it's thickened. There's edema and fluid around it, right? So this would be a nice example of a grade 1 sprain of the MCL. The fibers are not discontinuous to suggest a tear. A grade 2 would be a partial tear. A grade 3 would be a complete tear. This is just thickening and periligamentous edema around the MCL, indicating that this is a grade 1 sprain of the MCL. Okay, so very analogous to what we would expect on an MRI if we were diagnosing a grade 1 sprain of the medial collateral ligament. Case 13, we have bilateral radiographs of the hands. Notice that there is ulnar deviation at the level of the MCP joints, at the 2nd through 5th joints. There are no erosions here, right? There's nothing else aside from ulnar deviation at the MCP joints. So the most likely diagnosis here is not rheumatoid arthritis, it's actually lupus arthritis, right? Because there's a lack of erosions. And this ulnar deviation is typically reducible. That's another important finding here. In rheumatoid arthritis, the ulnar deviation is not reducible. So lupus arthritis is the answer here. Charcot's arthropathy, which happens from rheumatic fever, would also look very similar to lupus arthritis. Okay, so look for reducible subluxations and dislocations at the MCP joints, as you see in this case. Look, moving on to case number 14, we have an axial image through the proximal thighs. The question that we have here is, what's the next best step in management? Well, this is a case of necrotizing fasciitis and Fournier's gangrene. We see gas in the subcutaneous tissues between fascial planes of the muscles here in the proximal thigh, going to the scrotum. Nice example of Fournier's gangrene. Of course, this is a surgical emergency. We would do a surgical consult in this case of Fournier's gangrene, right? This is a do not miss MSK case. The key to making the diagnosis of neck fascia is looking at gas insinuating between fascial planes, between muscles. Gas just in the subcutaneous tissues is not enough for us to, potentially make a diagnosis on CT for necrotizing fasciitis, right? So this requires surgical debridement, and we would immediately take the patient to surgery. Moving on to case 15, this is an axial CT image through the hips. Notice we have all these osteochondral bodies within the left hip joint capsule. This is a case of synovial osteochondromatosis. There can be a primary and a secondary form. The most common location would actually be the knee. Even though I'm showing you the hip, the answer here is knee. This is a synovial metaplasia or proliferation of cartilaginous, osseous cartilaginous bodies. They can happen in joints, bursa, tendon sheaths. Most commonly occurs in the knee, and the hip would be the second most common place to get synovial osteochondromatosis. Case 16, we have a frontal and lateral view of the knee showing interesting findings. This patient would have an increased incidence of developing what malignancy? Well, we have multiple osteochondromas, right? We have these osseous excrescences that are coming out of the femur, the tibia. Remember, an osteochondroma has 3 characteristics. It's usually metaphyseal. they point away from the joint, and they have direct continuity with the medullary bone. Well, because an osteochondroma is a chondroid benign tumor, if it goes and becomes malignant, it would be a benign chondroid tumor. A malignant chondroid tumor. That would be a chondrosarcoma, right? So chondrosarcoma would be the answer in this case. This is a case of multiple hereditary exostoses. When you get multiple osteochondromas, you have a slightly higher incidence of going into chondrosarcoma, maybe 1 to 3% reported in many articles. Case 17, we have a sagittal and axial T2 facet images through the knee at the level of the meniscus. We have an example of a meniscal tear. What type of tear is this? Well, this is a radial tear. Notice that it's perpendicular to the tibial plateau. The tibial plateau is running like this. It's perpendicular to that, and it's also perpendicular to the long axis of the meniscus. This is a C-shaped meniscus, and this is the tear right here, right? So it's perpendicular to not only the long axis of the meniscus, but perpendicular to the tibial plateau. That's the definition of a radial tear. The answer here is a radial tear, okay? So again, radial tears are oriented perpendicular to the long axis of the meniscus and to the long axis of the tibial plateau. Case 18, we have an MR image through the extremity of the bone showing a finding. There's obviously a fracture here. There's a hypointense line. There's bone marrow edema. There's subperiosteal edema. Well, what grade of stress fracture is this? Well, this is a grade 4, right? Because anytime you have a hypointense fracture line, that's automatically a grade 4. A grade 1 is when you just have subperiosteal edema and nothing else. A grade 2 is when you have periosteal or subperiosteal edema and marrow edema on T2, but the T1 looks normal. No fracture line. A grade 3 is when you have subperiosteal edema, marrow edema on T2, and on T1 it's dark. But again, no fracture line. When you start to see a fracture line, like in this case, it's a grade 4 stress injury. Moving on to case number 19, we have a frontal view of the leg. Notice that there are sheet-like calcifications in the soft tissues. That should be a buzzword for dermatomyositis or polymyositis, as it is in this case, right? So remember, calcific tendinitis was globular amorphous calcification around bursa or tendon sheets or joints. Myositis ossificans is, the zoning pattern where you get calcification and ossification more peripherally and then, centrally later as it matures. Tumoral calcinosis is usually periarticular, globular, a lot of calcification, typically in African Americans. Okay, so this is a nice example of what dermatomyositis would look like. Linear sheet-like calcification. Moving on to case number 20, we have sagittal CT image through the spine and an axial CT image through the shoulders. We have these H-shaped Lincoln log vertebral bodies, right? End plate depression centrally. We have sclerosis and serpiginous sclerosis along the humeral heads, AVN, H-shaped or Lincoln log vertebral bodies. Nice example of what sickle cell disease would look like, right? So the underlying disease here is sickle cell disease, right? Osteoporosis would just be diffuse osteopenia. Renal osteodystrophy would look somewhat similar, but there would be, sclerosis along the superior and inferior end plates without the depression, right? Hepatic disease would be enlargement of the vertebral body, typically picture and frame vertebral body, different than the sickle cell disease that I'm showing you here. Nice example of this. You can also get acute chest syndrome, interstitial opacities in the chest, cardiomegaly, surgical clips from cholecystectomy, a whole host of findings in sickle cell disease. Case 21, we have a trauma case with fractures. Notice that there's a fracture of the proximal ulna. There's a dislocation of the radial head at the elbow. What's the most likely diagnosis here? Well, with that pattern, you should automatically think of a Monteggia fracture, right? Mugger. Monteggia for proximal ulnar fracture. Galeazzi is usually a radial fracture, right? So this is the definitions here. An Essex Lopresti would be a comminuted radial head fracture and disruption at the wrist of the distal radial ulnar joint. Okay, so you should be familiar with these mnemonics for classic fractures in the forearm. Case 22, we have an axial CT image in bone windows through the head. This is pointing at a lesion here, right, in the anterior ethmoid air cells. What type of matrix mineralization is expected in this tumor? Well, this is a paranasal osteoma, right? It's an osteoma, very common in the paranasal sinuses. In fact, 75 to 90% of osteomas occur in the paranasal sinuses. Well, it's a bone-forming tumor, so it's going to have osteoid matrix mineralization. Remember, matrix is the substance that the tumor is producing, in this case, bone. Mineralization is the calcification associated with that matrix. This is osteoid matrix mineralization, right? So That's what an osteoma is. Again, up to even 90%, 75 to 90% occur in the paranasal sinuses. Case 23, we have a frontal view of the hand and a MR axial T2 or coronal long T2 facet image through the foot. Notice that there are marked lucencies in many of the bones, the phalanges, the metacarpals, and we have these lesions in the foot, many of which have flow voids in them, right? So what's the most likely diagnosis here? Well, this is a case of Maffucci syndrome, right? We have multiple enchondromas in the hands, and then these are all multiple hemangiomas, right, in the foot. When you have the combination of multiple enchondromas and multiple hemangiomas is Maffucci syndrome, right? O'Lears would just be multiple enchondromas, okay? So nice example of this. Now, O'Lears and Maffucci's have a higher risk of malignant degeneration to chondrosarcoma than like multiple hereditary exostosis. Remember, that was 1 to 3%. This can be up to 25% according to the literature. Case 24, we have a sagittal T1 and sagittal T2 facet image through the shoulder. This is at the level of the supraspinatus. What ultrasound-guided treatment can be performed for this entity? Well, if you look carefully, I know the tendon is black, but there's a circular focus that's even darker than the tendon on both T1 and T2. This is what calcification looks like. This is what calcific tendonitis would look like on an MRI. Of course, we can do ultrasound-guided lavage and aspiration as an ultrasound treatment for calcific tendonitis. So remember, I showed you the X-ray appearance of calcific tendonitis. I want to show you now the MR appearance for calcific tendonitis as well, right? It's going to be very low on both T1 and T2. Case 25, we have a sagittal T1 weighted image through the knee and a sagittal T2 facet image. The question we have is, what's the treatment for this entity? Well, if you take a look carefully, there's all these low signal bodies on both T1 and T2 within the synovium and the joint capsule, right? All this studying, the posterior joint capsule is dark. It's dark here. There's even dark signal in Hoffa's fat pad, even in the suprapatellar recess, in the posterior joint capsule. This is what PVNS or pigmented villonodular synovitis, or now known as tenosynovial giant cell tumor, would look like. Of course, a synovectomy is the treatment for this entity, right? So look for dark deposits on both T1 and T2. On gradient, they will bloom, meaning they'll get even darker on gradient echo imaging. Okay, nice example of what tenosynovial giant cell tumor or PVNS will look like. This is proliferation of blood or hemorrhage within the synovium. Case 26, we have multiple MRI images here. T1, T2 post contrast. We have these lesions that look like they're associated with nerves, right? You can see the nerve bundle going into it and out of it. It's dark on T1, bright on T2. They enhance with post-contrast imaging. These are, multiple neurofibromas, right? When you have multiple neurofibromas, that's usually an indicative of NF1. That would be in chromosome 17, right? So multiple neurofibromas are seen in NF1. That's chromosome 17. Neurofibromas are typically dark on T1, bright on T2, and they have avid enhancement on post-contrast imaging. Case 27, we have coronal images of the ankle bilaterally, right? The question that we have here is, what's the most likely diagnosis? Well, notice that there's osseous fusion or coalition between the talus and calcaneus on one side, and on the other side, this is not really degenerative changes. There's, close apposition with jagged, ill-defined, ragged edges, again, at the talocalcaneal articulation. So this is actually an example of tarsal coalition. On this side, it's an osseous coalition. On this side, it's a fibrocartilaginous coalition. There's no bone bridging it, but there's fibrous or cartilaginous tissue that's bridging it because of the jagged, ill-defined, ragged edges and close apposition between the two bones. Nice example of tarsal coalition. 25 to 50% of these can be bilaterally. Remember, in the ankle, the two most common places to get a coalition are the talocalcaneal and calcaneonavicular bones, right? Nice, very nice and cute example of a tarsal coalition. Case 28, we're almost done. Going to 30, we have sagittal T2 facet image through the ankle and a lateral view of the ankle. Notice that we have prominence to the anterior or the posterior superior process of the calcaneus. We have Achilles tendinopathy, and we have retrocalcaneal bursitis. Those triad of findings should suggest Haglund syndrome, right? You have the Haglund deformity, prominence of the posterior superior process of the calcaneus, plus Achilles tendinopathy, thickening and degeneration of the tendon, and retrocalcaneal bursitis, all examples of Haglund syndrome. Okay, so the triad of findings is Hagelin syndrome. If you have just a deformity that's prominent posterior superior process of calcaneus, highly associated with high heel shoes in females. Okay. Case 29, we have a frontal view through the SI joints. These SI joints are markedly abnormal. What's the cause for the patient's radiographic findings? Well, notice that there's bilateral symmetric sacroiliitis. There's sclerosis, there's lucency. These are all erosions on the bilateral aspects of the SI joints. Look at all these erosions. It's bilateral, it's symmetric. That should make you think of the seronegative spondyloarthropathies, particularly Angst-Bahn or inflammatory bowel disease. If you look very carefully, it's hard to see, but there's surgical sutures here in the right lower quadrant in this patient that had Crohn's disease. So this is an example of IBD arthropathy with bilateral symmetric sacroiliitis, right? So C would be the answer here. Now, osteitis condensus ilii would result in sclerosis along the iliac aspect of the joints, typically seen in pregnant females or middle-aged females. Hyperparathyroidism can also result in osseous resorption, subchondral resorption, but this is, a very nice example of bilateral symmetric sacroiliitis. If the sacroiliitis is unilateral, you always want to rule out septic arthritis, right? Always want to rule out septic arthritis. And finally, last but not least, we have an ultrasound image through the shoulder, and the arrow is pointing at what structure? Well, this is the greater and lesser tuberosity. The structure that sits in the bicipital groove is a biceps tendon between the greater and lesser tuberosity. So this is a nice example of what the biceps tendon would normally look like on ultrasound, right? Hyperechoic ovoid structure that sits in the bicipital groove. Always important to look at that to make sure it's not empty, because then the biceps tendon can be dislocated as well. Nice example of a simple biceps tendon, okay? So that's it. That's my MSK board review. This is part 1. I'll do another one soon. Please subscribe to my channel if you haven't already, the MedED page. Please follow me on Twitter at Awan Rad. I hope you will all ace the MSK section of the core exam. Thank you so much for your attention.